Well, welcome everyone. On the behalf of the LAM Foundation, it is my pleasure to be with you all for this October educational session in our LAMposium in Your Living Room series. My name is Charlene Dunn. I am the Patient Outreach Coordinator for the Foundation, and we thank you for joining us as we bring LAMposium into our living rooms. This series evolved from the speaker schedule we had prepared for LAMposium last spring, and I invite you to learn more about the series and to view recordings of previous sessions by checking out our LAMposium in Your Living Room landing page on the Foundation's website. Before we get started, I would like to take a moment to thank our generous sponsors, the Dater Foundation, Pfizer, and NDRI, the National Disease Research Interchange, for their support of this educational series. Just a quick couple of housekeeping items. Microphones will be muted throughout the presentation. The chat box is open for questions related to Dr. Strange's presentation, and our moderator will read the questions to Dr. Strange either at the end of his presentation or following his lead if he opens for questions throughout the presentation. And now it is my pleasure to introduce Susie Picard, our moderator for this evening. Susie is presently and has been our LAM liaison in Region 6 for coming up on 12 years now. I think the 12-year anniversary mark will be December of this year. Region 6 covers North Carolina, South Carolina, Georgia, and Eastern Tennessee. Susie is also one of the founders and active moderators of the patient Facebook group, LAMmies. Outside of her engagement with the Foundation, Susie maintains extensive, beautiful gardens at her home in Cary, North Carolina. She is also kept busy and active with, entertained by, and occasionally exasperated with Murphy, her energetic and adorable blue-eyed Shih Tzu poodle, or Shih-Poo, who, last I heard, has ditched his favorite chew toys in favor of Susie's face masks, of all things. So with that, Susie, I would like to thank you for moderating this evening, and I will turn this over to you.
Yeah, my dog did. He's torn out some of my face masks. So I wanted to welcome everyone. We are pleased that you're joining us this evening. And I do want to thank the LAM Foundation on behalf of Women with LAM for providing us a way to hear some of the presentations that would have occurred at the LAM conference in Cincinnati. One of the many things that makes LAMposium so special and unique is the opportunity to ask questions and talk with the specialists, the doctors and the researchers who treat patients and who study LAM. You will get this same opportunity later tonight. I believe another thing that's really special about the conference is meeting other women who share our diagnosis. And as you talk to others, you may hear what are often similar stories and experiences. And it's nice to meet and connect with new people. Many times, these women become our friends. Tonight, I have the pleasure to introduce our patient spotlight, my friend, Adriana Alvarez. Let me go to my screen.
Hi, how are you? I don't know if I can speak, but hey.
Okay. So I'm actually going to tell your story. So Adriana was born and raised in Venezuela. She loved being very active. She told me she would go hiking in the mountains, and she exercised often and really enjoyed participating in Zumba. Adriana went to college where she completed programs in both social communication and also pharmacy. But she didn't end up working in either field because very shortly after graduating, she was offered a job working for a famous sculptor whose work she loved. And with that job came the opportunity for world travel. And being young and adventurous, that's what she did. Adriana moved to the US. She currently lives in South Florida near Miami. And like many of us can relate to, her life was altered following an emergency trip to a hospital for what was gallbladder pain. Some scans had been taken, and they told her she needed to follow up with a doctor for her advanced emphysema, which she thought was absurd because she wasn't even a smoker. But she followed up and went to a pulmonologist who shared with her that he believed she had LAM, along with a grim prognosis. He wanted her to have a biopsy just to be sure it wasn't cancer. And she was told this news just 4 days before her wedding. She was 29 years old then. Adriana got married, and 10 days after her wedding, she did have that biopsy. It confirmed her diagnosis of LAM. And then just 2 weeks later, she experienced her first lung collapse. This was followed by pleurodesis surgery. After she was discharged from the hospital, she went home to recover, but just 5 days later, her other lung collapsed. So in a span of about 6 weeks, Adriana had had a biopsy, a diagnosis, both lungs collapse, and pleurodesis surgeries, one right after the other. Now, I believe most individuals would have a hard time with that, but we tend to be strong women, and Adriana is exceptionally strong. After some months of slowly recovering, she started trying to exercise again. She turned to social media and connected with other women with LAM, leading very active lives, and they inspired her. Now, Adriana's nature has always been to challenge and push herself. She told me she wanted to do something that will make people go, whoa, she has this, but she can do that. So one day, while searching for fitness options, she looked on Groupon and she discovered an aerial silks studio less than a mile from her house. Now, for those of you who do not know what silks are, they're these long pieces of fabric and they're anchored to the ceiling or beams, and you climb and wrap up in them and hang and hold poses. It takes a lot of strength, and I would think some courage too. Well, Adriana fell in love with it, and she got better and better, and it became a passion for her, so much so that she started her own business, opening her own aerial fitness studio called Silk Arts. She certainly succeeded in making me go, whoa, she has this and she can do that. And that concludes our patient spotlight. Hopefully you'll get a chance to say hi to Adriana in the group discussion toward the end of this evening's program. So next I have the honor of introducing our featured speaker for tonight, Dr. Charlie Strange. Dr. Strange is professor of pulmonary and critical care medicine at the Medical University of South Carolina in Charleston and is the medical director for AlphaNet. Dr. Strange received his undergraduate degree at Davidson College in Davidson, North Carolina, and his medical degree at the Medical College of Virginia in Richmond. He has been at the Medical University of South Carolina for more than 35 years. Dr. Strange has an interest in rare pulmonary diseases and co-directs a LAM and rare lung disease clinic for patients throughout the Southeast United States at MUSC. He is known as an expert in alpha-1 antitrypsin deficiency and is an expert in bronchoscopic lung volume reduction for COPD. Dr. Strange is the author or co-author of more than 200 publications, presentations, book, and computer chapters. We're pleased Dr. Strange will be presenting tonight. We appreciate his willingness to spend time with our community. Those who go to the Charleston LAM Clinic know how genuine he is in the care and treatment of his patients and in his ability to educate and explain concepts. And on a personal note, Dr. Strange, who always asks us to call him Charlie, has been my LAM doctor for over 10 years. And during that time, he's traveled several times here to North Carolina, where I live. It's about 4.5 hours away, to lead our regional meetings. This is just an example of how generous he is with his time. So thank you, Charlie. And as a reminder, if you have questions during his talk, please make a note of them. And following Charlie's presentation, there'll be a period of time for addressing these. So it's all yours.
Thank you so much, Susie. It's my honor to be sitting in front of all of you tonight, and I hope I don't upstage the vice presidential debates. I'll try and be presidential. And we've got a really hard topic tonight. We're going to talk about all of surgery, and yet I'm not a surgeon. So to kind of put things in perspective here, we're going to talk about pneumothorax, which I do have a passion to try and fix. And then we're going to talk about some of the other surgical things that happen in the lifetime of LAM. This opens up to all kinds of questions. So I'm planning to talk for about 20 minutes. And then after that, we'll open up and just take questions one after the other. I love that sort of format because we really get what's on your mind and can respond the best way we do. And then we have Dr. Moss sitting in the wings here. So if I don't know anything, I'm going to just call him up and ask him to have a chat as well. So my first thing I'm going to do is to share my screen, and let's make sure that it pops up and everybody sees that. Okay, so this
Yeah,
is just
we can see it.
okay, it's just my introduction here. But our outline for the evening is to talk about pneumothorax, and then when we have a pneumothorax, we want to try and prevent the next one. That's a process that's got a big long doctor's word called pleurodesis. And that just means trying to make the two parts of the lung and the chest wall fuse together so that you can't have a pneumothorax anymore. Chylothoraces, another big doctor's word, is when we get chyle in this space of the pleural space. We're going to talk about what the pleural space is and kind of why this fluid gets in there. We're going to talk about some kidney tumors, angiomyolipomas, and then they added lung transplant to my list, recognizing we could talk for a whole hour about lung transplant, but we'll just have a few words about that one. So when we start in and say, what is LAM? Everybody gets the rare lung disease, but the next word out of almost everybody's mouth is associated with frequent pneumothoraces. And I know of the 80 plus people we have on the call tonight, a majority of you have had one of these. So it's not one of these rarities in the community. But I think how it happens is really not been explored quite as much as it possibly could have. I'm going to start this talk, though, with a slide that Frank McCormick gave me. And he gave me to this when he came to Charleston and talked about LAM for our rare disease day 3 years ago. And he told the story of Andrea Burns. As you know, this was more than 25 years ago at the very beginning of the LAM Foundation, that the whole LAM Foundation was initiated when Andrea had a pneumothorax during an air flight when she developed shortness of breath on her way from Cincinnati to Denver in 1994. She was found to have a tension pneumothorax. This is where there's air between the lung and the ribs in the pleural space, and it keeps getting larger and presses and compresses the heart over into the other side of the chest, making patients have a low blood pressure. They rushed her to the emergency department. She had a chest tube there, and the CT scan showed diffuse cystic lung disease. And so a thoracic surgeon there called in for her pneumothorax was the one that actually told her that she had LAM. And younger picture many years ago, and I'm sure that we contacted Andrea before this, make sure she wouldn't mind letting her story be shared across this, but this was Frank's slide and presented her case as how prominent pneumothorax really has been in the history of the LAM Foundation. And so we're going to move right on into kind of talking about this disease and what it is. I've drawn here a schematic of some lungs, and if the pink part's the lung, then the lung fills both sides of our thoracic cavity, but it has a lining on the outside. And that little tiny blue line right here is a thing called the visceral pleura. Visceral just means it's adherent to an internal organ. And the lung is wrapped in this connective tissue matrix that's probably about 1/2 inch thick in the human pleura. And it keeps the lung keeps the air inside the lung and keeps the air from going into this potential space between the blue line and the brown line. The brown line is called the parietal pleura. And this is a lining that sits right underneath the ribs on the chest wall. And there's just a minuscule amount of fluid in between that lets those two surfaces rub back and forth. So when you take a deep breath, your lungs can slide up and down underneath the ribs. And that fluid has been characterized as about 1 milliliter, about 1/5 of a teaspoon of fluid around the whole area of the lung that sits here in this potential space called the pleural space. So the space isn't really a space at all. It's just a potential space so that if you were to get a hole, then that space can enlarge with air, or in the case of chyle, to get fluid in that space, a thing called a pleural effusion. So a pneumothorax is simply air that gets into this pleural space, and it gets there by rupturing through that visceral pleura, the blue line here, from the cysts in the lung that pop through and then make a communication from our windpipe and trachea out through the lung and then into the pleural space. And what happens is that the lung collapses. As that air in the pleural space gets bigger and bigger, the lung gets smaller. And what happens when the lung gets small is the heart has to push all the blood through the good lung that's still inflated. And so not only does the ventilation and the airflow go down in this lung, but also the blood flow goes down as well, and it makes people short of breath. And there's the risk for this little rent in the blue line to become a one-way valve, so that air gets in and it doesn't come back out through the same hole. And that's a thing called tension pneumothorax. So it's like a one-way valve effect. So the air gets in but can't get back out again. So what does it look like? So you walk into the emergency department and you're short of breath and shoot an x-ray. And what you see here is this little lump right here. And this lump is the lung that used to be all the way up underneath all the ribs. And if you take a picture of a CT scan, black is air, and this is all air in this pleural space. And this little circle is the entire lung, that on the other lung would have all sorts of blood vessels and holes inside of it. And so this is a very large pneumothorax. This is 80% of the thorax filled up with air in this space. And what has to happen here is we have to get this air out. And so we can put a tube in and suck all that air out, and the lung will just magically re-expand and touch the surface underneath the ribs again as it moves on through. So how often does this happen in LAM? And there are some nice review articles that have been put forward by the scientists in the LAM community, suggesting that of 1,591 patients from 7 different series and 2 different studies, this has happened to more than half of people in the LAM community. And once it happens, it usually happens a second time. That cyst that's sitting there and leaking didn't go away. And so the risk for it to happen and the lung to collapse is there for a second or a third time. And this is always the wild card. I think it's the scary thing about having LAM and having one of these. You never know when this thing is going to happen again. And shortness of breath and some squirrely little chest pains happen much too frequently. And so it makes people get scared about, am I having another pneumothorax or not? The average number of recurrences have been measured about 3 to 5 in these different series of patients. And most of them happen in the first year. So once you've had one, you're at risk for a second. And it's often the first manifestation of disease. It's usually on one side only, but think about when one lung collapses, it puts some more pressure on the other lung to ventilate and you'll be breathing faster. And so there are people that get a pneumothorax on one lung, and because of the rapid ventilation, they put some extra tension on the other lung and get bilateral pneumothoraces, one happening in each lung. And that's a real scary situation. I want to show you what has happened historically in LAM and why we have very specific recommendations. And the hardest part here is that first one is sometimes you don't have a diagnosis yet and it's managed and that lung keeps leaking. And so the average time in one of these 7 series was a month in the hospital to get all this fixed. And we have some of those really bad stories in the LAM community about the 1-month hospital and what that meant for everybody. And so our goal is to make sure that doesn't happen very often. And we're always trying to move things upstream so that we take care of it the first time and do it the right way. So we know a lot about pneumothorax from our other diseases in which this happens. And the most common of these are cigarette smokers who smoke and get emphysema, part of the disease of chronic obstructive pulmonary disease or COPD that you see on the news all the time with some drug or another. We have studied this enough to know that, for instance, if you watch all the pneumothoraces that happen in Puerto Rico in a year, you can actually correlate the number of events that show up at emergency departments with changes in barometric pressure. So it's one of these situations where our atmospheric pressure changes the pressure inside the lungs and increases risk. So we have advised all LAM patients not to go bungee jumping. And I'm sure this is going to be a disheartening thing for everybody on the call here tonight, but that means that we really don't want you skydiving or scuba diving as well, because these pressure changes inside the lung with the air pressure change are a risk, and LAM is unique in its risk for pneumothorax. And Nishant Gupta had a very nice study that in which he showed that it was cost effective for every single person in the world when they show up with a pneumothorax and a female between the ages of 25 and 55 for the emergency department physician to get a CT scan, because it will show LAM often enough that we can make diagnoses when the previous plan was only to shoot a chest x-ray and put a tube in and not get a CT scan. So you'll find that almost every emergency department in America gets a CT scan at time of pneumothorax. That's a good thing. It's come from research supported by the LAMmies. So how do we prevent these from happening? Well, this is just a picture of all the holes that happen inside of a lung in patients with LAM. And I think it's hard because it's not usually just one hole inside there, it's lots. And many of these sit right underneath that pleural surface. And they do eat away at that lining of the lung called the pleura that helps hold the air inside the lung itself. So I don't think we have a good strategy of how to prevent pneumothoraces from happening. Once a lung collapses, though, we'll see the individual cysts inside of here. And the chest tube that goes in is a tube that goes between the ribs. There's this golden triangle here that starts underneath the armpit and goes down and tries to avoid the breasts and some of our big strap muscles in the back. And we get a tube in there to suck the lung back out so that it reaches the ribs again. And then we're trying to prevent the next pneumothorax from happening. That happens usually with an agent for pleurodesis. And pleurodesis is that second big word that we're going to learn tonight, which is that process by which we're going to try and stick the parietal pleura up to the visceral pleura and make those two pleural surfaces fuse together so that they can't collapse again. The two agents that have been used historically for that are a chemical called talc. Everybody knew this when you were a kid it was baby powder. And in our early days in the 70s and 80s, we actually would buy baby powder and take it down to the hospital pharmacy where they would sterilize it and we would put it up inside chest tubes to be able to do this. What happened about the mid-1980s was that we realized that talc, which is really just a rock that's been ground up, comes in lots of different sizes, and the little tiniest of particles can make their way through some of the lymph connections inside the pleura and make its way into the circulation. So we found talc particles in kidneys and other parts of our body that we didn't like having there. So now there is only one form of talc. It's made in France. It's all of the same particle size that can't make its way into blood vessels. And talc can either be taken at surgery and blown across the surface like a powder of the surface of the visceral pleura and sit there at time of surgery, or it can go in through the chest tube, and both have been shown to be pretty effective at preventing the next pneumothorax. And I'll show you in a minute that the more frequent intervention is actually to go in with a scope called a thoracoscope, where the surgeon pops between the ribs with a little tube and looks at the surface of the lung and does a thing called abrasion. They'll just take a gauze and rough up the surface of the visceral and parietal pleura so that when the chest tube is left behind, that area of roughed up surface will then heal and create a fusion between the parietal and the visceral pleura. And a surgeon can be just light and gentle when they do that, or they can be real aggressive and try and get it red and raw on the inside. And so every surgeon has their own unique technique about how much of the lung surface gets a surgical abrasion and how much and whether they use or don't use talc. And so most thoracic surgeons these days, particularly with the potential for some future lung transplant 30 or 40 years down the line, will do a surgical abrasion but not throw the talc on for fear of making too thick a surface of that fusion. But the goal is to get that lung back up with the chest tube and have the two surfaces oppose each other and to heal so that that lung can never collapse again. Obviously, the other lung is still at risk for pneumothorax, and so it's rare that we do bilateral pleurodesis procedures, but those have been done by some individuals in the past. Back in 2006, there was this wonderful study where Dr. Al-Musa and colleagues went to, Joel, I think you might have been on this one, when they went throughout all the series of patients with LAM that had had a pneumothorax to see what had actually happened. And 301 individuals had their first pneumothorax. And of all of those individuals, 147 of them had a second pneumothorax. And indeed, 59 of them over here on the far right had a third pneumothorax. And they divided this into 3 different groups of therapy. Conservative therapy means they put a chest tube in and they just watched it. They didn't put any chemicals or didn't do any abrasion in the pleural space. And what happened was 66% and 60% of the people receiving conservative therapy had recurrence of the collapsed lung again. The talc, and there's also an antibiotic called tetracycline that used to be used with more frequency, had 30, smaller number of individuals treated this way, 30 and 26, but a much lower recurrence rate of 27%. And then the individuals that had surgery, one of these abrasion pleurodesis procedures, had recurrence rates that were the lowest of all in the 2 series here. And so right now in the thoracic surgery community, I think surgery by thoracoscopy has become the standard by which most people should be treated. And because of these really high recurrence rates, we actually wrote and believe that this should be done on the very first occurrence. And many people that haven't heard this before or don't know that they have LAM when they have their first pneumothorax, the usual for COPD and for other kinds of pneumothorax is wait for it to happen a second time before that starts with a surgery. So this is different for LAM, and it's something that the LAM community has been very vocal in trying to make sure it gets advanced. So that's pneumothorax. I thought I would go ahead and chat on about the chylothorax. This is a process by which our lymphatics are abnormal, and where the lungs are supposed to be black and filled up on this chest x-ray, all of this white stuff is a fluid. And so when a needle is inserted into the pleural space and fluid is pulled out, it's this white milky fluid that's full of lipid, full of fats. And these fats are what travel through our lymphatic system and just happen to rupture into the pleural space. And this person, there was fluid on one lung and also on the other. And sometimes it can really be quite prolific. But it's part of this whole process of lymphatic disorders that happen inside of LAM. The pleural fluid can compress the lung and make people short of breath. So we don't like having chylothorax, the chyle inside the pleural space. And we found that this presentation with LAM is very sensitive to the effects of sirolimus. And so when you give sirolimus to patients with chylothoraces, usually the fluid goes away and our lung returns. You can see the small cysts here in this CT scan, but there's no more fluid. And then now the patient can breathe again because you're using all parts of your lung instead of just the other pieces. These same sort of lymphatic collections, though, also happen inside the belly. And so this is a thing called a coronal image, which means this individual standing up, and this big organ's the liver, and the pelvic bones are down here, and the heart and the lungs are up here. You can see all the way through the abdomen here. And these collections are abnormally dilated lymphatics. And so that lymphatics and lymphatic collections can happen lots of places, and they can leak into other organs, and they can sometimes rupture into the pleural space and give these chylothoraces. And these collections are responsible sometimes for the lymphedema, the swelling associated with the lymphatics that happens in the rest of our body. And they also tend to respond to sirolimus. And this is after 3 months. We see all these big collections have basically disappeared in this individual patient. So we know that sirolimus is effective and reverses these chylous effusions, and cystic lymphangiomas is what we call these collections of of lymphatic fluid there. The lymphatic system is just one of those one of those vessel systems inside our body that's outside the blood vessels. We don't talk about it very much in medicine, but everybody knows about our lymph nodes up in our neck that tend to swell when we get a sore throat. That's our lymphatic system responding with increased inflammatory traffic through its system. But there are different chains of these lymphatic vessels that move through the belly and up into the chest, and ultimately up into the neck and empty into a thing called the thoracic duct, where it empties back into the heart. And so it's just that whole process of occasionally people can have chylous ascites. That means fluid in the abdomen. Lung congestion can happen from some of these, and different areas are sometimes have swelling in the rest of our body. Our next topic was, should we ever operate on kidneys? And the answer is not unless you have to. But everybody realizes that a fair number of individuals with LAM have angiomyolipomas. So let's break this word down. Angio is the root word for blood vessels. Myo is muscles, and lipoma is fat. And so these are tumors that have all three different cell types inside of them. They can happen on the outside of the kidney, or they can happen inside the kidney. And with the blood vessels that flow to these, they are prone to have bleeding episodes. You got to realize that the blood flow going to these things, though, is coming off some pretty big blood vessels. So this big red blood vessel is the aorta. And to be able to say, well, let's stop this bleeding here, we would have to go up the aorta and down the kidney artery, it's called the renal artery, and find a little subsegmental artery that goes to this little collection of tumor, and put a little blockage right in that little artery right there to stop any bleeding that would happen. But this is what our interventional radiologists do every day for strokes and for all sorts of different things that happen in our body. And so this is the way, rather than surgery, that we think this should be done these days if we have bleeding. If you have a tumor on the outside of the kidney, then sometimes the bleeding will happen outside of the kidney as well. And that blood can move back in some of our collections around our back muscles and and really generate lots of pain and lots of bleeding. So we can put a lot of blood back there before enough to drop our blood pressure and not necessarily recognize where it's coming from. So this whole process, though, is again going through the vascular system to find the blood vessels, to be able to occlude the bleeding vessel, to make these bleeding events stop. And we have plenty of people in the LAM community that have had a kidney taken out, and you only get so many kidneys in life. So we would rather do kidney sparing or vascular blockade to stop bleeding events should they happen. But this is the story of the AMLs, the angiomyolipomas. I was going to say a word or two about lung transplants. I found this pretty picture on the web. This is what your lungs look like when all the blood's been taken out of them and they're trying to preserve them after they've come out of a donor and are headed towards the lung transplant surgery suite. And obviously there are lots of questions about who gets lung transplants, who, when, and where, the whole waiting process. What's the surgery like? What's the recovery like? And that whole post-operative experience. And so I think I'm just going to suffice to say, usually this happens when our lung function is very low, usually FEV1's less than 25%. We do have this rough age cutoff of about 70 years. There are a few lung transplant centers that are doing things a little bit into the 70s for if you have no other diseases. But the key feature here is that when the quality of your life is not coming back and the risk of death is higher with keeping your LAM lungs, as sick as they may be, compared to the risk of death that would happen if you got a lung transplant. We usually get 2 lungs, a double lung transplant for LAM. You get better lung function when that happens. And there are lots of online resources for this. And so I'm just going to show you the slide. It's a little sobering for this 1-year mortality that happens after a lung transplant has been done. And then the waiting times are widely divergent at different centers, and those are all published on the web as well through the United Network of Organ Sharing, organization called UNOS, that is empowered to follow all of this. Your likelihood of getting a lung is based upon a thing called the lung allocation score, and UNOS keeps all the scoring systems going to figure out who should get the lung, taking the most sick individuals into the lung transplant arena first. The blue line are the lung transplant survivals in 13,000 individuals up to 2001, the green line up to 2009, and the red line, the most recent 7-year experience that's been published. Now, if you look at this, you got on the x-axis all the years after year 1. And I think the way these survival curves should be thought about is if you have 100 individuals that go and get a lung transplant, how many individuals are still alive at each of the subsequent years down here? And so if we call a thing where the 50th person dies, a thing called median survival. And so median survival has gone from 5 years up to 7.5 or 8 years over the more recent decades in all comers of lung transplant. The most common diseases these days that get a lung transplant are not LAM, because LAM is so rare, but there's cystic fibrosis and idiopathic pulmonary fibrosis, 2 other diseases that don't have as good survival as LAM does. And there's a very nice review just in LAM that came out, and the LAM transplant survival is about 10 to 15 percentage points higher than this. So the curve is a little bit better than the red curve, but it's not 100% across the top. And I think the reality here is that you want to keep your lungs as long as you can, even if they've got LAM, as you move through with these sorts of survival curves. And we can take questions about this and other people. We can spend a whole hour talking about lung transplant another night. But you don't want surgery unless you have to. But the first pleurodesis for the first pneumothorax makes sense. Sirolimus works for these chylous pleural effusions. Interventional radiology is the preferred approach for bleeding, angiomyolipomas, and lung transplant truly is a last resort in my mind and most other individuals as well. So I'm going to quit sharing, and I went a few more minutes than I planned to, but that leaves us still plenty of time for questions, and I can answer questions as long as the appetite is there. So thanks for hearing me out tonight.
Thank you. Thank you, Charlie. Susie, go ahead. And so we have, yeah, Susie, what we'll do here is feel free, yeah, you're unmuted, to type your questions into the chat box. Don't be shy. This is your opportunity to ask directly to Dr. Strange. And with that, now we're all set and unmuted. Susie, go ahead and take it.
Okay, so I'm going to start with one question that was submitted via email. And this person has asked, are there any surgical interventions for those of us who have chylous fluid leaking via the uterus? Being on Rapamune, sirolimus is supposed to help, but it hasn't for some of us.
Okay, so what we think happens with sirolimus is that these LAM cells that are causing dysfunction of the lymphatic system begin to shrink. And as the LAM cells decrease in size, then usually the obstruction in the lymphatics decreases, and now lymphatic flow can get reestablished up through the body, those chains of lymphatics that end up going up to the neck and into the blood vessel. Sometimes they don't, and sometimes it takes a long time. And I've heard of someone taking sirolimus for up to 1 year before all the lymphatics normalize back to normal. And then there are some people just get leg swelling or other swelling areas in our body that happen intermittently, even though they're taking sirolimus. So I think sirolimus, you're right, is not the full answer for everybody all the time, but we do like to give it a good 6 months to a year. So I don't know how long the sirolimus has been going, but we don't like to be doing surgeries to try and find and interrupt lymphatics unless we have to. The key down deep in our body, like at the uterus, though, is to be able to find out where these leaks are happening. And sometimes these are little pinholes. They're very, very hard to find. It depends a lot in the uterus, obviously, on whether there is any interest in using the uterus for anything purposeful downstream of pregnancy, which generally the answer is no. And so hysterectomy would cure this, but that's a big surgery. There are some other techniques, for instance, wire mesh up inside the uterus that often gives a scar. We use this to sometimes fix fibromas, another benign tumor inside the uterus. And I'm wondering if a wire mesh ablation might cut off a leak like this. So I'm talking, but I'm not the expert here. And this is a very, very rare problem I've never heard of before. So you're pushing me on that one. I don't know that I have all the answers.
Thank you. So here's a question. Do you recommend surgery with mechanical and talc on the first pneumo? This person had a stretch where she had mechanical with tetracycline, which held for 20 years before she required another surgery, and they used talc.
Yeah, I think if you've had the first surgery, what we know in patients across the board with all pneumothoraces is that surgery alone with mechanical abrasion is about 95% effective for the average person that doesn't have LAM and pneumothorax. And you saw that those numbers are not as good, at least in the experience in the LAM community. So people have experimented with whether to do this with talc. If you do abrasion pleurodesis and then add talc on, we get more talc absorbed into our blood vessels. And so generally most thoracic surgeons don't want to do that. So it's usually one or the other, but in the series that did not have LAM that got both the abrasion and the talc, then the success rates were 99%. The other thing that is sometimes done if you failed one mechanical pleurodesis or abrasion pleurodesis is a thing called it's actually a pleural stripping, in which you take that lining, connective tissue lining of the pleura and grab it and pull it off from the rib surface. And good thing they have you asleep, because that would be very painful. That's where all of our pain nerves lie, in the pleura. And so, but that one's about 100% successful. And so I don't have all the answers here. I'm not the surgeon doing these, but typically people, when they go in with a second after a first abrasion pleurodesis, are just going to be more aggressive with their abrasion technique the second time. And if there are adhesions that have already formed along the pleural surface, and you get in with your thoracoscope, you can see where those are and go back at the places that didn't have adhesions develop last time. The last consequence of this abrasion process, though, is sometimes people can have pneumothoraces, but your lung won't collapse. Or if it collapses, it'll collapse in just little tiny places. And we have so many intermittent pains that happen in the LAM community that we're pretty convinced that some people have these little microscopic pneumothoraces, but the lung can't collapse, and yet they're going to heal on their own if you give them enough time. And as long as the lung doesn't collapse, it's still a safe procedure to let the lung have little micropneumothoraces now and again after an effective pleurodesis. So I think there's a lot we don't know about how effective pleurodesis is. But as a general rule, we're going to go back with abrasion and take it on again if there's enough space for the thoracoscope to get into the pleural space and do some work around these second events. If we just took the tack that everybody at first event had an abrasion pleurodesis, we'd have many fewer of these second events to then happen and have to deal with. So I think that's priority number one, at least for me.
Okay. You've kind of answered some of these questions with that explanation. Somebody has asked what other substances besides talc are used during pleurodesis.
Yeah, so through the years, there have been many different substances used. Silver nitrate has been used. If you nick yourself shaving, you pull out the little styptic pencil, and that is pretty effective, but it hurts. The same way it hurts here, it's going to hurt in your pleural space. Tetracycline was used for many years until There was a large study of autopsies done after somebody had a tetracycline pleurodesis. They went into these pleural spaces and found almost no fibrosis in any of them. So we don't really recommend tetracycline very much anymore. There was early work in the 1950s and 60s by taking some of your own blood and putting a blood clot into the pleural space, arguing that blood must be able to make an effective pleurodesis happen. And that was proven in animals to not be effective unless it also got infection at the same time, and that's a risky procedure. So we don't think that blood patch pleurodesis is a very effective mode. So that's what has led us really to the abrasion pleurodesis is the best way to go for most of our surgical colleagues.
So someone wants to know, how would we know if you have chyle or an AML, she said. How do you know if you have chyle or an AML?
Okay, so usually, well, it's going to take an x-ray picture. So I think all of us in the room here recognize that when you have shortness of breath and it gets really bad, you better go somewhere and get a chest x-ray done. A CT scan is always more sensitive than a chest x-ray on picking up a pneumothorax. But we don't like the radiation to be given over and over again. It's a CT scan is about the same radiation exposure as about 40 chest x-rays. But it is more sensitive when you're trying to figure out about how much air is in the pleural space and exactly where it is. So I think it's hard. These, if you've just been getting slowly more short of breath, your lung doctors are going to pause and take a chest x-ray from now and again, wondering if you might have developed some chyle in the pleural space and be compressing the lung. And that's an easy explanation for why shortness of breath is developing, because that's something we can fix. And we have a much harder time fixing the cysts of LAM, for instance. And so I think it's, it is always, nobody knows unless you take x-rays, and that's why we pause and get those sometimes.
And I want to piggyback on that question. So if somebody finds out they do have an AML, do they have to be treated? That is, can a person live with them without treatment?
Yeah, so I probably have 2/3 of the individuals that I follow for LAM have at least an AML in there, it seems. And I followed some of these for more than 20 years. And we do believe, at least from the early Cincinnati papers, that sirolimus has at least some activity in AML size. So I guess the largest AML that I follow is 30 centimeters. That's more than a foot long. And so a kidney that is bigger than a football inside there, just full of AMLs. And this individual has done really, really well for 20 years on real low dose sirolimus and not had any bleeding events and just goes on with life. And so we don't really have to do anything with these. And I think of all the tumors that happen inside kidneys, this is one of the most benign. It's not that it can't have problems. We want to be able to deal with the problems when they happen. But I think just because you have a kidney tumor that's an AML doesn't really make you have to do anything except know that it's there. And we're going to be checking if there's blood in the urine, or if you have pain around the side of your back on either side where these kidneys lie, then it ought to be investigated. But I think it's one of these things that can sit there for years and years and really not cause any problems at all.
So we have a question from someone who asks, can pleurodesis be done during pregnancy?
Well, we don't like to do any operations during pregnancy except deliver babies and then get things done. So technically it can be. It's a risk. We do only emergency surgeries that can't wait during pregnancy. So if you were to have a pregnancy, the pregnancy precipitated your LAM, and your first presentation of LAM was your pneumothorax, I think that's a hard call about whether you just let that first pneumothorax be treated with a chest tube alone, or whether you actually go to the operating room and go under general anesthesia and get a pleurodesis through a thoracoscope and an abrasion or not. I think if it was me, I'd probably do it even though I was pregnant. But anytime you give anesthesia and potentially drop a blood pressure, you're putting that baby at some risk too. So that's a hard decision. I think those are going to be individualized decisions between individual patients they make with their doctors.
So you had mentioned pleurectomies, and one of the individuals here has had a pleurectomy on each lung in 1982. Is this usually a permanent solution?
Yeah, so after we have been at least 1 year since your last pneumothorax, it's pretty rare that we have another one downstream. So most of these happen within the first year of your last one, and it's not impossible. That's why we don't want you bungee jumping. But at the same time, I think it's one of these situations that usually means if you've been that long without it, it's probably not going to happen again. And so I think everybody lives on the edge of their chair for the first year after their first one of these, because you remember the experience so vividly and sometimes not in a pleasant way. So I think that's why everybody sits on the edge and thinks about it. But at the same time, a year's gone by and you haven't had another, it means you're probably not going to have any downstream, at least on that same lung. And yet we're always at risk for the other lung to have one if you only had one lung involved.
She had both.
Yeah.
So you said no bungee jumping and skydiving. We have a question. What about roller coasters? This person has moderate LAM and wears oxygen on exertion.
Yeah, I don't know. What do you think, Susie? That's a hard one.
Roller coasters. My family did. I mean, I went on roller coasters.
Yeah, and I think the other thing to say is that
not the ones that did the loop, but you know.
Yeah, I know, but you obviously you're changing some barometric pressure by going up and down that quickly. So I don't think we've done this study of how many LAMmies had their pneumothorax after roller coasters yet, but we did call the FAA to look at how many people have pneumothoraces after air travel, which is another big question. You're on vacation, one of these happens, can you get home again, or do you have to drive? And there's a lot of burden associated with having to drive after you've been on vacation somewhere. And we called and asked about a 5-year period. This has been about 5 years ago, and the FAA had zero record of any pneumothoraces happening while in flight. And I think over a 5-year period in all of America. And I think that means that people got off the airplanes and were short of breath and they rushed onto the emergency department and didn't know it, but at least we don't have, this is not an everyday occurrence that Andrea and others have had in the LAM community. So we really don't know the right answer to how long you have to avoid these big barometric pressure changes that happen with air flight and with roller coasters. But it's usually estimated that about 1 month after your pneumothorax happened, you should probably lay low for a while. Does that mean you have to not come home on the airplane? I think we pressurize airplanes to about 5,000 feet, but it's still a difference of barometric pressure that happens when you take off and land in an airplane.
Somebody has asked about LAM and is it related to lymphedema, and doesn't sirolimus cause swelling? You said it, reduces chyle, but does it cause swelling? And to piggyback on that, what is your opinion on lymphatic massage?
Okay, so I'll take a lymphatic massage from anybody who wants to give me one. But the question is really around swelling versus lymphedema. And in the package insert of sirolimus, there are many side effects if those you want to pull it out and read it. And one of them actually is edema. Edema is a doctor's word that just means you got swelling, and lymphedema is one of these kind of, it's a colloquial term. It's a term used only in the South to recognize that when your edema doesn't go away after they give you Lasix and other diuretics, so it must be your lymphatics that are making you fat or having extra swelling there. But lymphedema technically means that you're not able to take fluid out of your connective tissues of your body through lymphatic channels. And it's not an easy diagnosis to make, but typically the lymphedema that I've seen is when one leg swells up but not another, and you look at the blood vessels inside and there's no blood clot there to cause the swelling downstream from that. So you assume that it's lymphatics, and sometimes we'll increase the sirolimus dose around episodes of lymphedema that happen. if you do fancy scans in arms and legs that are swollen, you won't necessarily see those big collections like I showed you in the belly on that very dramatic CT scan. So I think the answer is that we often don't know, and we'll look at our sirolimus dose and maybe increase it a little bit to see if swelling goes down and make the disease by association. Swelling in an arm or leg, though, is more commonly due to blood clots, and blood clots can be very serious because they can break loose and move through our bloodstream and land up in our lungs. If you're already lung compromised anyway, then putting some blood clots in the lung, called pulmonary embolism, is a very dangerous situation that we want to make sure that we don't just take a swollen leg that hurts a little bit and say, it must be lymphedema, and not get it evaluated. So we do think an ultrasound there looking at the blood vessels is the right test to do. And when you don't see anything abnormal in the blood vessels, then we can make a diagnosis of default by saying this probably is due to some of the lymphatic abnormalities that happen in LAM and tend to get better on sirolimus therapy. Yes, sirolimus sometimes causes some swelling as a consequence, but so do a lot of other blood pressure medicines. And so just having some swelling doesn't mean it's sirolimus. It needs to be evaluated in the context of all the other medicines you might be taking. Now, I don't know very much about massage. Can't hurt. Sounds good.
Sounds good. Can you get AMLs on other organs, specifically like the adrenal gland instead of the kidney?
Yeah, you can. And the characteristics by having these three different cell types of blood vessels and fat and muscle can really happen anywhere in the body. It's just they tend to happen a lot more often on the kidneys. I think it's usually when we see them on a kidney and they have fatty components to them, we don't usually biopsy those. We look at the scan, we say, oh, that's an AML, and we're done with the diagnostic workup. When you have LAM already, we're very aware of people getting all sorts of biopsies and resections for tumors, not knowing what they are. And so when these things start showing up on other organs, it's not so obvious that these are AMLs. And so people will sometimes go and actually take biopsies to make sure they're not something more serious.
So someone just asked a question which would you could answer, especially for the new people who may not be aware. It says, my mother was just diagnosed with LAM, and I was researching and read most people diagnosed live only 10 to 20 years, and 20 years is rare. From viewing the chat, it seems some are living past that. I'm wondering what the average life expectancy is with someone diagnosed with LAM.
So this person's looking at all of you and saying, you all sure do look old in there. And yet I think we realize that there is a lot of literature out there where many of our rare lung diseases were diagnosed very, very late. And so I think that what's on the web has to always be taken with a grain of salt. And we have the same sort of, my other disease that I treat a lot is a disease called alpha-1 antitrypsin deficiency. And the exact same wording is there when we know that we have our 90-year-old patients sitting out there who were short of breath, but they've been around for about 60 years with their alpha-1. And so I think it's really and sirolimus, I think, has changed the natural history of this disease as well. So I think we have no clue. I think the LAM Foundation did their fun analysis of trying to contact everybody that ever touched in any way the LAM Foundation and figured out how long the average person had their disease. And that number, Sue, I think was 32 years. So the point is 20 years is only half of what is probably out there now. So everybody on here gets to live another 40 years from today is my answer, because we're going to come up with a cure, right? So
I hope so. I hope you're
right. We're going to go for it.
So we've had a couple questions about LAM affecting other places. Can LAM affect the liver? Can LAM affect the breasts?
So I might have to turn to Joel for some of these questions, because I don't actually, we know that the chylous collections can happen inside the liver. There are plenty of cysts that have a chylous communication. We see many different About 10% of all of us have a liver cyst just being there that we were either born with because the liver didn't fully develop, or it developed over time with the aging process. And so, so we see abnormalities. At autopsy, we can find these LAM cell clusters that I showed on my very first slide throughout the whole body, but they usually don't set up shop as avidly as they do inside the kidneys and the lungs. Joel, you want to say anything about the breast or the liver question? You're still on mute.
Unmute.
Yep. There you go.
So we've had AMLs in the liver fairly frequent, so that does take place. For patients that have tuberous sclerosis, there also been lesions in the breast. So you could picture them, especially patients that are mosaics in terms of tuberous sclerosis, having symptoms of LAM and some findings related to the breast.
Thank you.
We have someone who has lymphatic LAM only and does not have pulmonary cysts. And she wants to know, are you aware of anyone else who has lymphatic LAM only without pulmonary cysts?
Okay, so what's been shown in pleural fluid is that you actually can find these LAM cell clusters if you look hard enough. They're not really easy to find, but we want to make sure that her diagnosis actually is LAM, just because there are other reasons to have a chylothorax. And chylothoraces happen in other diseases whenever those lymphatic chains are disrupted up inside the chest or the neck. And so, for instance, we'll have one of our individuals that goes into the intensive care unit and gets a central venous catheter placed in their left neck and actually hits this thoracic duct that drains lymphatic fluid into our blood vessel. And next thing you know, they have a lot of this chylous effusion in their right chest. And you wouldn't think that these two things are related, but it was actually a damage to the drainage system. So we want to make sure that these are two independent diagnoses. Just having a chylothorax alone does not give you a diagnosis of LAM. If you have LAM, then yes, you can have almost no cysts inside the lung. And so it just means that we'll find people that have an established diagnosis of LAM, even by open lung biopsy or some other invasive biopsy-driven process, that have almost no cysts and normal lung function, and that's a good thing for catching that disease early.
So you mentioned you could nick something. Someone has asked, how safe is an abdominal biopsy? Will the chyle spread in the abdomen? And I don't know if she has an issue with chylothoraces or not.
Yeah, so in the old days when we were struggling to get a diagnosis, either of an AML and we didn't have VEGF-D available to us, we would sometimes biopsy almost any organ in the body. And I think these days we are not having to biopsy as often because we have VEGF-D, and many people that have a small cyst burden will take a presumptive diagnosis as well. I think it's not dangerous. Our radiologists these days working under their CT scans can put a needle anywhere in your body. And with a little numbing medicine, it's not too bad a procedure, but we try and avoid puncturing these big collections of lymphatic fluid because they tend to leak. And so some of these residual chylothoraces can really be a problem for a few months. And we think that they got there by one of these large abdominal collections of lymphatic fluid being punctured or falling apart, sometimes under the influence of sirolimus, and then just leaking into the pleural space for a really long time. And so we tend not to biopsy unless we have to. Any time we are thinking about, we have to really understand what we're going for at the biopsy, and most of the time it's not for a diagnosis of LAM.
I have another email question. I'm not sure if I understand it exactly, but the question is, does stopping menstruation, will it help pleurodesis? And will it and pain from shortness of breath stop?
Okay, so there is a disease in which people have a pneumothorax every time they have their menstrual cycle. And that's because they have a disease called endometriosis, which is uterine tissue that has migrated through the body and come up through into our pleural space. And we have a little nodule of endometrial tissue that every time you have your period, it involutes and sloughs off just like the lining of the uterus. And when the lining of the pleural space, that endometrial tissue sloughs, now the air can come out of the lung and the lung collapses, and it happens once a month. That'd be a bad thing, right? So in that situation, you suppress menses and all of their pneumothoraces get better. So one of our questions when you just show up with a pneumothorax out of the blue is, well, when was your last menstrual period, and have you ever had a pneumothorax before, and do you get pain in your chest with every menstrual cycle? And this is endometriosis in the chest that presents, and this is a big long doctor's word called catamenial pneumothoraces. We make up big long words for all sorts of fancy diagnoses, and these, I've seen probably 5 of these in my life. It's a really rare thing, but there is a fair amount of endometrial disease associated in the LAM community. And so I have never seen a LAM patient with a catamenial pneumothorax. Joel might have.
Someone has asked, how does sirolimus work in reducing chyle?
Boy, I wish we knew. What we think is that these LAM cell clusters at least plug up some of the lymphatic structures. And so if sirolimus decreases the burden of LAM cells and lets them not be as large and not proliferate and prevents proliferation, then these lymphatic channels, they're like little tiny blood vessels in our body, can open back up and let the chyle drain through these blood vessels in its normal channels. And what's been found is that there's one big channel that comes up through the chest that moves up along the right side of the heart called the thoracic duct. And surgeons every now and then are in there taking out lung cancers and other things in their surgeries, and they will either have to take the thoracic duct or do it by mistake. And what happens is those thoracic ducts that have been injured by surgery will actually grow back together over time. So these lymphatics can find each other and put themselves back together if you just let them be for a while. So we do believe these are injuries to the plexus of lymphatic vessels that can heal themselves under the influence of sirolimus when sirolimus prevents the blockage due to these LAM cell clusters. And there's probably also an effect just on the lining cell of the lymphatics, which are similar to endothelial cells, lining cells of blood vessels themselves. And so there's probably a lot more molecular work that needs to be done there to sort that part out, but that's my plumber's mentality approach to how sirolimus helps the lymphatic abnormalities in LAM.
Someone has asked, this is a family member, what would be your advice for someone that was just diagnosed within the last 2 weeks? As a family member, what should we be aware of? So what would you tell family members that come?
Yeah, I think it's important to know about pneumothoraces because they happen with enough frequency that you may be put into a position to help your family member make their way to the emergency department to make this diagnosis if they develop sudden shortness of breath and chest pain on one chest or another. And so it's always our nature to try and make sure if you have an acute symptom or it's just a little shortness of breath or just a little chest pain that you kind of just follow it on along and see how it goes. But I think it's a little bit different, at least and a little bit scary on the front side of LAM until you understand what the chest pain bit is all about here. And so I think is to be alert and supportive of chest pains that happen in this community and to try and figure out what's dangerous and what's not dangerous is a little bit of a learning process, but let the patient be at the center of that and to really understand what's out of the ordinary when you come in with out of the ordinary chest pain or shortness of breath, it could be a pneumothorax.
So I think I was trying to scroll back through to see if I skipped anything. Shar, you can help me if you see something that I missed.
No, I think this has been fantastic. Amazing questions and very thorough answers. Just so, but I think we've covered it. Does anyone?
There's one more.
Yeah, we've got another one just came in.
What is the youngest age where LAM has presented? And Dr. Moss might know this too.
Yeah, I'm gonna kick that one to Joel. It's probably one of the TSC kids, age 3. What's your guess? What have you seen?
Youngest we've seen is about 16.
Oh, okay.
No. There is a report of a child having looked like LAM in the lung, but it's not clear whether it's LAM or it's an AML.
Okay.
So more questions are coming through now. What are the odds of getting both chylothoraces and pneumothoraces? So how frequently does that happen that somebody has both those issues is what I think she means.
Yeah, no, I think it's not infrequent that when we have a pneumothorax and we put a chest tube in, that we get a little bit of fluid out. And that fluid can have a little bit of a milky appearance to it. And it may be that you've injured some of the lymphatics in the process of putting a chest tube in. So I think we see that bit. I've not personally seen both a pneumothorax presenting and then on top of the pleural fluid of a chylothorax at the same time, but they clearly can happen. They're not independent, and the chest tube will take care of both of them. So it's just one of these things that I'd be curious if somebody did have that happen. Put it out there if you'd like to.
Can LAM be hereditary?
So the sporadic LAM is not hereditary. The TSC component with tuberous sclerosis complex can be hereditary. And so this is where one of the LAM center physicians can help newly diagnosed individuals sort out which variety of LAM that you and your family members have. And so I think that's an important question. And it's getting in to see one of your wonderful and numerous LAM centers around America where people have really stepped forward and are willing to take on this rare disease, because the average pulmonary guy has only 1 or 2 of these patients that they've seen in a lifetime. And to just recognize that not everybody knows everything is an important part of this business.
What is the prevailing theory on how the cysts form?
Oh, that's a hard one. So the prevailing theory is that the LAM cell clusters incite an immune response in which some of our chemicals that fall from this actually eat away at the tissue inside the lung. And there are a number of chemicals that can eat up parts of the body. They are called proteases, which means they cleave proteins, and the center of the lung has many different kinds of connective tissue matrix chemicals that are there, including collagen and elastin. And so we don't really understand the full connection between the LAM cells themselves and then the response of the inflammatory cells that move in and then elaborate the injury. LAM cells themselves might have some of that injurious features, but this is why we have the LAMposium, where you get to learn all about the basic science if you choose to walk across the hall and try and understand this better. And I don't think we have a final definition of why those cysts happen. Because if we knew that, we could potentially block that chemical, that process, and prevent progression of cyst size. And at least we tend to have a little bit of progression of cyst size even on sirolimus. And I think that's the piece that we're worried about in this new world post-sirolimus, is that we still have a little bit of lung disease progression with the aging process, even while on sirolimus. And it's not the cure-all for everybody. And that's what we're all working for the cure to find.
Susie, real
Yeah.
quickly, I'm going to circle back to our very first question in there and make certain that we have some clarity for this patient. She's asking, what provides a better clear of a pneumothorax, a CT or an X-ray? And is it possible to have a small pneumo not show up on an X-ray?
It is absolutely possible for a small pneumothorax not to show up on a chest X-ray. The next question is, are you going to die from your pneumothorax that doesn't show up on a chest X-ray because it's so tiny? If you've already had a pleurodesis, the answer is probably not. And so sometimes we'll shoot an X-ray to reassure a patient that this is not a large pneumothorax. If it's there at all, it's going to be small. But if you really have to know, then you've got to get the CT scan done. And the CT is just very exquisitely sensitive for who has the pneumothorax and who doesn't. If you're on room air that's 21% oxygen, the air that you leak into your pleural space has 79% nitrogen in it. And nitrogen is not absorbed by our body very easily. It's said that when you get nitrogen in your pleural space, 1% of that gas volume is resorbed every day. So you can have a pneumothorax sitting there for a really long time, even if your pain was last week. That let a little bit of pneumothorax in there. So you will not miss this on a CT scan if you come the next day and figure out if you had that pain yesterday was a pneumothorax or not. The air will still be there inside the pleural space, unless you're on almost pure oxygen that gets absorbed very easily.
Thank you.
Then there's a little bit, individual questions for the from symptoms, and you're gonna take a stab at these. There's one individual who has had a bad week because when she lays on her left side, she gets a sharp shooting pain and pressure. And she's, of course, she's worried if she has a pneumo. What would you tell someone that feels sharp pain when they lay down?
So what happens with pneumothoraces are infrequent enough that most people describe this as one of the worst pains they've ever had. Not everybody does, but most people do. Air in the pleural space is very irritating to the lining of the pleural space and the nerves that sit just underneath there. I think the other thing to say is that there are also other kinds of pains inside the chest. So those of you that have had a chest tube know that when we put a tube between the ribs, there is a nerve and a blood vessel inside between those two ribs, and that nerve can be injured. And so about 2% of people, 2 out of 100 people, will have some nerve injury that leaves kind of a numb feeling along that particular rib that moves around, in a thing called a post-thoracotomy pain syndrome. And so it's the injury to the nerve that happens whenever a surgeon's been inside the chest. And those pains tend to be pretty severe in some people. They tend to diminish over time. And we have a different set of medicines we give for those kinds of pains. These aches and pains that happen up and down a left side, that happen intermittently, I think we have to individualize, because that's the conversation about, is this pain similar to what you've had before? Or is this out of keeping with the past? Is really the process of being a doctor and having a good doctor-patient relationship, where you understand and try different things for the pains that happen. And that's it's a really hard thing for this community, because there is a lot of pain that happens intermittently and really can be quite severe and not be pneumothoraces out there. And I don't think we understand that well enough.
So one individual has described a pain or a sensation of a band tightening around her chest, and she thinks that she has suffered from nerve damage as well. And is that common to have this band tightening sensation?
Yeah, it is not common. There are some of our diseases that do have a band-like sensation, but you got to realize that the nerves that cause pain in our chest sit in this parietal pleura, and right underneath the nerves there. And the lung itself has very few nerves that have pain associated with it. Most of the nerves inside the lung cause cough. And if there's an irritant in there, it can be, for instance, even going down with bronchoscopy and our tools that we work on inside the lung, there's really not pain associated with this. So most of these pains are coming from the chest wall, which is the rib side of the pleura. And these subpleural nerves can be irritated by things happening in the lungs, like pneumonias and other things. But sorting those out is really, I think we could have a whole hour session on the different kinds of pain inside the chest and what to do about them, because I don't think we have answers for many of them. And it does take a pretty comprehensive workup to try and understand what's going on for these.
Then I have one more question concerning the immune system. Let me try and find it. Is
treatment of LAM and lupus the same? And the answer is no. We'll occasionally use sirolimus for other diseases, particularly some of our transplant. Lupus, this is an overactive immune system disease, and we tend to suppress the immune system in that disease. And anytime we suppress the immune system, even if we do so lightly with sirolimus, we do end up risking infections as the consequence of that. So that's shared between lupus and LAM, in which the more sirolimus and the higher the levels we get, we are a little bit extra risk of infections when we use that medication.
Anyone else?
Once going twice.
No, people are thanking you.
Well, you're very welcome. It's been my pleasure being on with everybody. And any of y'all are welcome to come to Charleston anytime once we all start flying again. Otherwise, it's a pretty long drive from Wyoming, huh?
Yeah.
So it's been my pleasure and glad to help you with LAM in your living room. Bye, everybody.
Thank you, Charlie.
Thank you very much, Charlie. Have a good evening.